Hello and welcome everyone. Thank you for joining us this evening for the fifth webinar in the MyIBD Learning webinar series, Tips and Tools for Managing Costs of IBD. My name is Bronwyn Kearse and I'm the Manager of Education Engagement at the Crohn's and Colitis Foundation, and I'm so pleased to be co-facilitating tonight's program. The Crohn's and Colitis Foundation is continuing to provide the latest information on IBD to our patients, caregivers, and everyone during the pandemic. The MyIBD Learning webinar series will feature different topics each month, and by registering for today's webinar, you've automatically been registered for this series, which takes place on the third Thursday of each month. I would really like to thank our event sponsors, Gilead, Janssen, Takeda, and Bristol Myers Squibb for supporting the MyIBD Learning webinar series. Their support enables the Crohn's and Colitis Foundation and our partners to continue providing important education for patients, caregivers, and alike. We encourage you to explore the webinar website to learn more about our monthly programs. We're very excited about them, and you can read about our presenters as well, get to know them and their background. Please also take the time, if you're comfortable, to upload a photo of your profile. You can use this to help facilitate networking opportunities and connections with other attendees that join. Under the homepage of this new platform that we're using, you can find different tabs to get to the agenda, join the live webinar series, watch and record, or watch the recordings of previous webinars, as well as learn more about upcoming webinars. You can also connect to local support groups if you want to, or your local foundation chapter. So many more opportunities that you can do through this platform. You can even learn more about the platform by going to the navigation Q&A tab if you have any questions. And of course, if you have any questions tonight during our program, visit the live discussion link. If you have questions, you can put them through. We have people there to help support you. One of the virtual help desk attendees will assist you. And before we get started with our presentations, I do want to go over a few housekeeping reminders before we begin. You've all been placed on mute for the webinar. All the presentations will be recorded and accessible to view after the completion of tonight's program. And of course, if you do have any questions for our panelists during this entire program at any point, please feel free to type them into the chat box that we have available. Now, I'm very excited to introduce you to my co-facilitator for this evening, Amy Bagwadia. Amy was diagnosed with ulcerative colitis at the age of 10. She has served as co-chair of the Foundation's National Council of College Leaders and is currently working towards her MS in community health and prevention research at Stanford University. Very excited to welcome Amy.
Thank you so much, Bronwyn. And I'm also very excited to join this evening's presentation and can't wait to share all of the wonderful information that we have planned for tonight. I would first like to introduce this evening's patient ambassadors and expert faculty who will be sharing their stories and expertise with us. We're privileged today to have Dr. Doug Wolf from Atlanta Gastroenterology Associates, Dr. David Choi, PharmD from the University of Illinois, Chicago, Jacqueline Spencer, the Manager of Patient Support of the Crohn's and Colitis Foundation, as well as our wonderful patient ambassadors, Jamie Holland, Adam Cook, and Brett Harris. Our first topic of the evening will be insurance appeals and denials, which will be led by Brett Harris and Dr. David Choi. Take it away, Brett.
Hello, everyone. I'm Brett Harris, a patient and a caregiver. I'm going to tell you a little bit about my story. So having been a caregiver of 2 children with moderate to severe Crohn's disease for most of the last 9 years, I have had my share of experience with insurance denials, some related to authorizations for procedures, for colonoscopies, endoscopies, MRIs, MREs, CTs, but mostly relating to biologic medications. My daughter has been on biologic treatments for the last 8 years for her Crohn's, 3 different biologics. And my son has been on a biologic since he was diagnosed 6 years ago. And it's not just a change in the medication, which has been an issue. Each time the dosage or infusion frequency has changed, we needed to go secure insurance approval. I am very fortunate to have an employer who provides me with insurance coverage. But my office has switched providers 3 times over the last 5 years. And at each change in coverage, we've had some challenges in getting the insurance authorizations. And of course, the effective date of the change in insurance is always right around, like, days away from their next scheduled infusion. So it's been a little bit hairy, but we've been able to get through it. The biggest challenge that I have, and the particular story I wanted to share, is that my daughter has been treated with dual biologic therapy for the last several years for her Crohn's and sacroiliitis, which is an autoimmune arthritis complication. We went through 2 rounds of insurance denials before her dual biologic treatment could begin. And then when my insurance switched, we had to go through 3 rounds of denials, even though it was a continuation of care and we had an infusion and injection schedule to keep up with. Fortunately, we prevailed in securing coverage thanks to our amazing pediatric GI practice who advocated on our behalf at every turn, a backup plan in place that was arranged through the pharmaceutical company, inside guidance on the process from our nurse case manager, who was assigned to us from the insurance company because we're a family with chronic illnesses, which is something that you wouldn't think is a benefit, but really has been helpful. And then my absolute stubborn persistence as a mama bear to advocate on their behalf. So I would like to introduce my co-presenter, Dr. Choi, who's going to talk about if he could let us know what are some of the circumstances when insurance denials relating to medication can arise, and how does the process work on denials?
Thank you so much for introducing, and I'm really thankful for you sharing that story. I think it hits home so much because thinking about our practice, these are the type of things that we run into every single day when we think about our patients. We know that in the grand scheme of things, the biologics are such important medicines to really get our patients into remission, and then maintain remission as well. And the really difficult part is navigating that process with insurance. So at this point, I wanted to transition the talk to talk about why do insurance denials happen? What are kind of the reasons behind it? What are the terminologies we may actually use from this setting, and going from there? So I'm definitely excited to be talking about kind of what's going on from that standpoint. So before getting started, there's a few definitions I want to go through to kind of establish the baseline. So there's some terminology you're going to hear about that people may speak of. So the first one is something called a formulary. So every insurance company will develop something called a formulary, which is their list of drugs that they approve for certain indications or certain settings. So they may say for inflammatory bowel disease, with Crohn's disease and ulcerative colitis, here are the medicines, our preferred agents, and this is our formulary. From there, they actually will give further designation to the medicines to something called step-based therapy or step therapy. And really, this really means we have to try certain medications first, or certain medications will be considered really the first line therapy. This is most likely because it's less expensive, because we know biologics are actually very high cost medicines. So the insurance companies are trying to curtail costs as much as possible. Or they may be a preferred agent because the guidelines, the national organizations are telling us this is the first line therapy, before then being allowed to move on to the next step. So that's why it's called step therapy. You're moving from step to step. The next option is something called prior authorizations. So prior authorizations are things that they're not formulary agents, and then you're actually either not going through step therapy or you're trying to move beyond step therapy too. This goes by a lot of different names. It may be called pre-certification, prior approval, but they all really mean the same thing. We're trying to obtain advanced approval before using the medicine as a cost control process. So they're really trying to make sure that it's indicated for the right condition. A lot of times what ends up happening is when a prior authorization gets denied, that's when we will do something called an appeal. So an appeal is really a request that we give to third-party payers or insurance companies to re-review their decision. We'll give additional information through letters of medical necessity or peer-to-peer discussions, and really making the case for why we need this to continue. So I think Brett mentioned this earlier, that there were multiple rounds that they went through. So it's multiple appeals that we would normally go through. So this is kind of a really simple version of kind of how the formula works. So really, once again, we start with the formulary agent. If it's the formulary agent, a lot of times no action is needed. This is covered. It's a medicine that can be used. But when we think about biologic agents, because of the costs associated with it, this is not really something you'll find a lot. We are kind of seeing it a little bit more where they are starting to have preferred formulary agents, but a lot of times they will all require prior authorization or step therapy. So step therapy, once again, it would be the next question. What does the patient have to try and fail first before they can move on to the preferred agent? But when we think about inflammatory bowel disease for moderate to severe cases where really we have to go to biologics, step therapy may not really be an optimal choice there. So because of that, we're not going to pursue this pathway. That then brings us to prior authorization, which is once again, we're asking for approval for us to use this medication. So if the prior authorization gets approved, everything's good to go. You can go ahead and fill it with the pharmacy and get it. If it gets denied, that's where the appeal, once again, as previously we discussed, kind of comes in, and it's the request to review the decision and have a medical director at the insurance company re-review the decision. So a lot of times when we come to an appeal, I think this is a really key moment where the team, as well as patients, I would, part of the decision-making process, one of the questions we'll ask is the appeal worth pursuing? Because a lot of work does go in there. And I think Brett mentioned it earlier too, with the nurse navigator, as well as all the team members that are just in that process to help approve it. It is a pretty labor-intensive process. There's a lot of follow-up. There's a lot of things that need to get done. But if it's something we have to, we definitely want to pursue, then it's something that we want to work on. So here, once we get a denial, there's really two pathways we can initially choose. So the first one is something called an appeal through a letter of medical necessity. That's where the doctor's office, the physicians will actually write a letter of medical necessity, explain the evidence behind their use, the indications, what, unique situations make it that we want to continue. So, I think in Brett's situation with her children, a lot of times it's continuation of therapy. They responded well. Here's the evidence, in terms of what we're trying to use. The other option we have is something called a peer-to-peer review. That's where the insurance company medical director can specifically talk with the physician, the prescribing physician, to have a candid discussion of why is this necessary and why is this a medication that we want to use. Sometimes the peer-to-peer can be delayed a little bit because you have to find a time that works for both the medical director as well as the prescribing provider. So sometimes it may take a couple weeks or a week or so to kind of get that scheduled, but that is a real good way of just having that back and forth between the two. So these are really the pros and cons. The letter of medical necessity can be just submitted immediately. It does take about 2 weeks for that to get reviewed in a lot of the cases. Peer-to-peer, it does allow for that direct, candid conversation between the two. The cons with the letter of medical necessity is they can only review what's submitted. So they can't have that question of, can you clarify this sentence, or can you clarify this point or this evidence? Really, but the downside of the peer-to-peer is that really you need to find that schedule that works for both the prescriber and the clinical reviewer as well. So, unfortunately, when a medication gets denied, a lot of times what happens is it's a formula for the insurance company. So there's literally check boxes that need to be hit before they can approve it. So even though clinically in certain situations it's absolutely appropriate and there's a total clinical need of using that medicine, because you didn't hit the checkbox, they may automatically deny it just solely off of that. So because of that, the appeal process can be somewhat, it may take a little bit of time to appeal it. So, just to give you some perspective, it can take anywhere from 2 to 4 weeks for this to really get appealed and reviewed. And it really kind of depends on the insurance. If the first appeal gets denied, there's always should be an option to do a second level appeal. That's where they'll consider it again. Maybe someone else will review it there. Something else that can happen if a second level actually gets denied is a request for an external independent reviewer. So this is where the insurance company will send this out to another company that specifically will be doing this as like a consultant or something along those lines. And they will actually review the data. They'll review the letter of medical necessity, the appeal, to ultimately make the last minute decision there. And really, I think for us, these are a lot of things that we navigate for our patients, especially at our current practice where we do have a lot of biologic patients that, we end up initiating. They don't follow the formulary of the step-based therapy. So So these are a lot of types of stuff that we're doing. And today there was a letter of medical necessity that I helped write earlier too.
Thank you so much both to Brett and Dr. Choi for bringing up such an applicable topic and sharing your expertise with us. Now, our next patient story comes from Adam Cook, who will be joined by Jackie Spencer, addressing common questions about patient cost and assistance programs.
Hello, everyone. My name is Adam Cook. I am a rising senior. I'm going to be beginning my senior year at Drake University in the fall. I'm from Des Moines, Iowa, and I'm a Crohn's patient. I was diagnosed with Crohn's when I was 12 years old, and ever since then, I have been working on handling and dealing with my illness. When I first was diagnosed, I went through the step therapy process, and fortunately, I'm finally on a medication that works for me. But unfortunately, now that I'm kind of jumping into the more adult world of finances and insurance, as I look towards the job market after graduation, I'm realizing how serious a cost a lot of these medications can be. And especially seeing how much a biologic can cost that I'm on, I'm really being much more aware and wanting to figure out any sort of ways that I can save money while still being a healthy and safe IBD patient. Fortunately, my current infusion center has actually helped put me on a payment plan and a payment program for my biologic. However, if for some reason that were to need to change, or for anybody else in my situation who's not on a payment or cost assistant program, I would like to ask a question for our presenter of how can they best choose a program, or how can one get a better understanding of some of these patient costs and assistance programs?
Thank you, Adam. That's a great question. There are a lot of IBD patients that are in that same situation. So there are quite a few programs that can help patients better afford their medication and their treatment. Let's start first with the cost of IBD care. There was a 2019 survey of insurance claim data. The data looked at 58,000 claim records of patients on commercial insurance and Medicare Advantage plans. So they found that, looking at the first image at the top, the average cost of insurance claims for IBD patients was about $22,000 up to $23,000 for an IBD patient, whereas non-IBD patient, the cost was about $6,900. So big difference there. Then looking at the image on the left, looking at out-of-pocket expenses, the cost for IBD patients was about $2,200 a year, where for non-IBD patients, it was less than $1,000 or $979. And then finally, other things that impact IBD patients is the cost related to lost time at work. As you can see, on an annual basis, the average cost in income was about $3,000 for IBD patients and about $1,000 for the general population. So here, there's some big costs that impact IBD patients. In the next slide, we talk about two major programs that help IBD patients. First, their patient assistance programs, and then their second, copay assistance programs. Okay. So let's look at patient financial assistance programs. There are many companies and organizations that help patients who need financial support. They cover medication, treatment, healthcare services, and the assistance programs can be based on a number of things, including your household income, the insurance coverage that you have, whether you have insurance or whether you don't have insurance. It also looks at out-of-pocket medical costs. For most of these programs, there are financial eligibility requirements. So each program has different requirements. Then there's something called the Copay assistant programs. These are copay cards that are offered by a drug manufacturer for a specific medication. These are for eligible patients. These are primarily for people who have private or commercial insurance. They are granted by the manufacturer of a particular medication. This offsets out-of-pocket costs for high deductibles and copayments. The eligibility requirement is different for each program. It's only for patients who have commercial insurance or private insurance. So they can't have public insurance like Medicare or Medicaid. And again, it depends on the terms of a specific brand or copay card program. Okay, these are not need-based, so there's no they're not going to look at your annual salary or anything like that. So it's not need-based. And then the length of the program varies. It could be up for a year for a specific dollar amount. But again, each program is different. There are a lot of programs out there. And so a lot of questions that we get in the Help Center is that, how do I find these programs? So we have put a list of programs together on our website. And our website is www.crohnscolitisfoundation.org/managing the cost of IBD. Now, on this website, you're going to find a lot of information. First, we're going to have the patient financial assistance program, but we also have other information on that site, like health insurance, what's covered, a glossary, frequently asked questions. So this is going to be a place where you're going to start your search for programs. So how do you find the program? So you're going to search by assistance type, possibly the pharmaceutical, financial assistance programs. You're going to look for specific copay cards. You're going to look for nonprofit organizations. These organizations might help with medication assistance, office copay assistance, transportation. You might need help with paying for ostomy supplies, lab testing, and then more recently, some programs on COVID-19 assistance. So there are many types of assistance that you can apply for. So there are some other tips to pay attention to just help reduce your costs. First, you want to partner with your healthcare team. You have to let your team know if you're experiencing financial hardship. If they don't know you're having a financial problem, they may not be able to help you. So definitely let them know if the cost of medication is challenging for you. Then ask your healthcare provider for medication samples. They may have samples in their office, so it may save you a few weeks of buying medication. Again, you want to consider buying in smaller quantities. Maybe instead of a 90-day supply, maybe you only need a 30-day supply. So that's going to save you some money. Then again, you want to consider brand, generic, or biosimilar. So there are cost differences between those types. Also, you want to pay attention to whether the healthcare services and labs that you're getting are in-network, because there's a big cost difference between in-network and out-of-network providers. And then finally, look for clinical trials. Maybe there's a trial that uses your medication, and participating in the trial, you may be able to get that medication. Okay. Finally, there's a lot of information on the website about resources. The IBD Help Center can help you look for those resources. So you can call us Monday through Friday, 9 a.m. to 5 p.m. Eastern Standard Time. Our number is on the screen at 888-694-8872, extension 8, or you can send us an email at info@crohnscolitisfoundation.org. Again, if you're having a challenging time searching and you need some help, we'll help you. So give us a call.
Adam and Jackie, thank you so much for shedding light on such an important topic and for sharing these incredible resources with us. Now, our next patient story will come from Jamie Holland, who will be sharing her experience with copay accumulators and will be joined again by Jackie Spencer.
Hi, everyone. Thank you for joining us tonight. I'm so happy to be here to discuss my experience with copay accumulators. I'm Jamie Holland. I've been living with Crohn's disease for over half my life. I've only been on medication since 2013, so it took quite a while to find the right medication and the right dosing to get into remission. I covet the treatment that I'm on right now, and when things like what we're about to discuss occur, it can rock you to your core. When I got married, I joined my husband's corporate health insurance plan in January of 2019. It is a high deductible plan, and I was nervous if the specialty pharmacy medication for Crohn's disease would get covered. Thankfully, it was covered, and since I had copay assistance, my responsibility at the time was $5. A bonus at that time, unknown to myself, my husband, and even some of the health insurance plan reps, was that the copay assistance paid our deductible in full. This was good news because our deductible was $7,250. I was really worried because that deductible, when you break it down over 12 months, would cost us around $605 a month, and that's just averaged. So the prospect of having to pay the high deductible left me questioning if I could even get a colonoscopy that year or not, especially troublesome because I was already overdue for one. A few months into the year, I started seeing fearful posts online in the IBD community about copay accumulators being added to insurance plans come the summertime. I reached out to people I knew in pharmaceutical world as well as university pharmacists to get their takes on this issue and to see if they had any suggestions on what could be done. In the back of my mind, I knew that this could happen to me one day. So when the fall rolled around and it was time to select the 2020 plan, there were no changes. I was relieved, but a little skeptical. So during the first week of January in 2020, I ordered my specialty pharmacy medication, and we met our deductible again, and it only cost $5. And there's a catch. As summer 2020 rolled around, I saw the same panic messages as the summer prior, and they were all about payment copay accumulators coming in. I again reached out to my contacts to see if anything had changed. They warned me that come 2021 insurance year, even more plans were planning to add copay accumulators. And sure enough, when the fall benefit election time rolled around for our plan, it was happening to us. I found the information in small print amongst the specialty pharmacy information that a copay accumulator program would be added to all of the insurance plans for the company. And the really weird thing is that the verbiage made it sound like it was a good thing. So if you're someone who's not familiar with this, you'd probably look and go, oh, this is good for me, but it's not. 2 letters were also sent after that to confirm that I understood that come January 1 of 2021, the copay accumulator would be in place and that the insurance company would pocket the money from copay assistance, and I would be responsible for my full medical deductible of $7,250. So this is a good thing for the insurance plan, but not for me. And I became really concerned if I could even afford my medication or my potential procedures for the year, or if we could afford our new bundle of joy that's supposed to be here this summer. So there was a lot of fear going on. My husband and I were preparing ourselves to go very, very deep into credit card debt, and that's a privilege that I know some people do not have. At that point, I reached out to my contacts once again and to see if they had any tips, and if what they had told me from tips prior still stood, and they did. They came through, and it was suggested to reach out to my doctors to ask about samples, which Jackie just discussed with us. It's always good to talk to your doctors about samples. And even if the doctor's office doesn't have samples, it's okay to say to your doctor or your doctor's nurse, can you speak to the rep and see if we can get samples? Unfortunately, the pandemic didn't allow for that to happen this year, at least at the offices that I go to, and I wasn't about to drive 4 hours to the university system. I was also encouraged to speak to my medications nurse program and explain we were getting hit with a copay accumulator for the new insurance year and to ask for feedback. So I did that. Thankfully, by reaching out to the medication manufacturer's nurse program, I was able to find some workarounds to make things more affordable. So, Jackie, my question to you is, what impacts have you seen copay accumulators create for our patients?
Jamie, thank you for that question. It has impacted patients by adding more cost to their healthcare. So you're correct, it's not a benefit that's helping patients. So a little bit about a copay accumulator program. They're also known as a benefit protection program. You might hear it listed as a coupon adjustment, an out-of-pocket protection program. These are all components of health insurance plans that might limit the value of a copay card and a discount coupon. It's a strategy used by insurance company and pharmacy benefit managers to stop a manufacturer's copay assistant coupon from counting towards two things. First, a patient's deductible, and second, the maximum out-of-pocket spending. So, Jamie, you mentioned that you had a $7,500 out-of-pocket payment that you had to make. So that plan is not helpful for that. Some of the challenges is that the manufacturers funds the prescription until the maximum value of the copay program is reached. So once that's reached, then the patient still has to continue to pay, but it doesn't count. The prior amount doesn't count towards the patient's deductible or out-of-pocket spending. And then after the point where the patient reaches that manufacturer limit, the patient's out-of-pocket payments begin counting towards their annual deductible and out-of-pocket maximum. So some questions to ask about a copay accumulator program. So how do you know if you have a copay accumulator program? As Jamie mentioned, it's buried deep inside your insurance plan. So you have to look at that, the medication information in your insurance plan. You should also receive a separate written statement or a letter from your insurance plan. Then you want to consult with your insurance company or your HR department to see if your plan actually includes an accumulator program. And again, just because it starts at the beginning of one year doesn't mean it won't be there in the next year. What should you do if you think you may be enrolled in a co-accumulator program? First, you want to call your insurer to clarify and to ask questions. Talk to your human resources department. They might not be aware that they've signed up for the program. So again, you want to just ask the right questions at the beginning of the year, just to make sure there hasn't been any changes.
Thank you so much to both Jamie and Jackie for hosting this important information and sharing this with us. Now, our final patient story will explore step therapy as well as the Safe Step Act, which myself and Dr. Doug Wolf will discuss. Now, to be honest with you all, I had no clue what step therapy was when I first heard the term several years ago. But then I quickly learned that this was actually something that had affected my patient journey, as well as the care of other IBD patients that I knew. I once met a 10-year-old girl who was diagnosed with very severe Crohn's disease. Now, immediately, having seen a case like this before, her doctor originally prescribed her a biologic medication, knowing that that was the right treatment for her. But unfortunately, because this patient had not tried and failed on other medications first, her insurance company refused to cover it. Now this, as Dr. Choi had alluded to earlier in the conversation, is an example of step therapy, also known as fail first. As this patient waited for this important medication to get covered, which took about a month or maybe more, her disease progressed and she unfortunately had to miss several weeks of school, not to mention endure physical and emotional pain as a result. And this experience is unfortunately not uncommon, and understandably, it can be extremely frustrating for both patients and caregivers to undergo. So, Dr. Wolf, I'd love to hear your thoughts as a gastroenterologist about this. Can step therapy affect any patient? And what advice do you have for IBD patients who are affected by step therapy in terms of best practices for communicating both with your clinical care team as well as your insurance company?
Amy, thank you for that awesome overview. And I hope that I can shed a little light on this. And so for starters, step therapy can affect anyone, and we'll get into that. And it's affecting people more and more. But what is step therapy? Well, it's also known as fail first therapy. It's a protocol or a strategy used by health insurance companies that require patients to try their insurer preferred medications, not the doctor recommended medications, the insurer preferred medication, before the insurer will cover the medication originally prescribed by the patient's physician, and often through shared decision making with the patient. And that might be, for example, a sub-Q biologic is discussed and agreed upon, but the insurance company wants to use an intravenous one, or it could be the opposite. The doctor and patient agree on a intravenous biologic because it might work better for them, and the insurance company decides on a sub-Q one. So step therapy protocols often ignore a patient's unique circumstances and medical history. Step therapy protocols are business decisions made by the insurance company, maybe with a pharmaceutical company or two. It's meant to save money, but it ignores the medical decisions that have been made through office visits and, doctor-patient interactions. Health insurers prefer step therapy medications from a business perspective to provide cost savings through agreements and contracts with pharmaceutical companies. So, does it affect me? Well, if you've been required by your health insurer to try a medication different from what you're prescribed, then step therapy affected you, and you've been subjected to that fail first or step therapy protocol. And in a 2016 survey by the Crohn's and Colitis Foundation, 40% of IBD patients said that they had been affected by these protocols. And in my experience, and those of other IBD specialists at this time in 2000, 2001, I'd say that the percentages are more like 50% or even higher. These protocols can delay optimal treatment initiation, and as Amy suggested and stated in her example, lead to irreversible disease progression and potentially lead to higher overall costs for the patient. So step therapy may occur if one changes jobs or parents change jobs, if the patient changes jobs, or if the company that one works for switches health plans, which can occur sometimes on a yearly basis, or you select a different plan. It can occur if you go on a new treatment regimen, but it can also happen if you have the same job, or parents have the same job, and the health plan is unchanged, but the health plan changes its formulary, which means that they change based often on financial or business decisions. They change which agent, maybe which biologic they are preferring in 2021, which may be different than what was preferred in 2020. So clearly, step therapy could affect you. So I thought I'd share a case study with you. This is a patient that I actually saw earlier this month for the first time. A 31-year-old male with ulcerative colitis diagnosed in November of 2017, went into remission on oral mesalamine medication. So that's good. He was diagnosed, he was treated, he did well, but within 6 months or so, he had lost benefit. He had lost response from this, commonly used oral medication. So the doctor taking care of him decided that based on this failure, he and his increased symptoms, he needed a biologic, and he was treated with an anti-TNF. And that was from July of 2018 to December 2019, almost a year and a half. And the patient went into remission. But as often happens, unfortunately, that remission was lost over time despite dose escalation, and another treatment change was needed. So the doctor changed him to intravenous biologic number 2, which he received for about 9 months and improved initially, but then lost response before a year of treatment. So then in October of 2020, and that's really just 6, 7, 8 months ago, there was a decision by this doctor and the patient that they wanted to try a different agent, a new oral agent that might work differently and last longer than the biologic. And it was FDA approved for ulcerative colitis, and so made good sense. But this well-known insurance company repeatedly denied the approval. In fact, the treating gastroenterologist requested a peer-to-peer call with an IBD specialist, and that was denied. So one of the examples that Dr. Choi gave earlier is something that insurers are increasingly denying us as providers to get. So we have to do letters. We have to wait 30 days, and it's very inefficient and potentially harmful to our patients. So anyway, this patient, after getting denied the medicine that was chosen, was started on a subcutaneous anti-TNF, which is approved for ulcerative colitis, but it didn't work. And the patient continued to be symptomatic. The doctor ended up treating this patient with prednisone, 40 milligrams a day, lots of steroid side effects. And despite the steroids marginally helping, he lost 35 pounds because the symptoms continued. And finally, he was referred to me a few weeks ago for management and assistance in getting an alternative medication. This other gastroenterologist had to kind of give up. And because I have experience in this, I worked with the patient, and we wrote a very detailed letter on the course over the last couple of years, what medications worked and didn't, and have already gotten approval of this oral medication that was denied before. So this all relates to the Safe Step Act of 2021. The Safe Step Act requires a group health plan to provide an exception process for any medication step therapy protocol. And so this bill establishes a clear exemption process and does require that insurers provide clear and transparent processes for patient or physician to request an exception to a step therapy protocol. And so patients can get it, but usually it does really involve the physician and the practice and the provider. And the Safe Step Act, which has been enacted in 31 states, outlines 5 exceptions to fail first protocols and grants exemptions. Of course, it's the insurance company that has to grant the exemption. The most common exemption being that if a patient is stable on a medication, they shouldn't be forced to switch from it. And of course, that makes perfect sense, but unfortunately has happened many, many times. Slide. The 5 proposed step therapy exemptions include that a patient has already tried and failed on the required drug. And although that makes perfect sense, patients are asked to do that not infrequently. The other, number two, to delay treatment will cause irreversible consequences. And I think being forced to use prednisone, certainly at a high dose for 1, 2, or 3 months, causes irreversible consequences, as anyone who's had this kind of therapy knows. There are other exemptions that don't occur as often, such as the required drug may cause harm to the patient. The required treatment will keep a patient from fulfilling their occupational responsibilities. Again, those examples don't happen often in the IBD realm, but the most common of these 5 exemptions is that the patient is stable on their current medication and should not be forced to switch. Slide, please. So, step therapy reform has occurred in 31 states, including the state of Georgia. And I'm from Atlanta, and I was part of step therapy reform. I played, a role of course, with many others in getting that passed through the Georgia legislature a little over a year ago. So many of you do have protections from fail first protocols if your insurance is, contingent on state criteria. And you can find out if your state has step therapy by going to this website that's listed. But legislation needs to be passed in all states, in the other 19 states, and in Congress to cover both the state, which are marketplace, state employee, and fully insured, as well as federally regulated private health plans. So that's a little confusing, but again, there are a lot of different hybrids of plans, and so we need both state and federal protection. And I was part of Day on the Hill, interfacing with legislators and legislative offices in Washington just this past week to try to achieve this change. And I think we're making some progress. Slide, please. So step therapy is something that is advocated for strongly by the Crohn's and Colitis Foundation, and again, both at a state and a national level. But the people who send the best message, providers, doctors and pharmacists, we can send our messages and they do listen. But legislators love hearing patient stories. And so you all are honestly the best advocates, as you can already sense from the presentations given by patient ambassadors tonight. So please consider joining our efforts at advocacy at the Crohn's and Colitis foundation.org/advocacy, or this other website to share your story, because all our efforts are really patient-fueled, volunteer-fueled, and you will be so helpful in making these changes if we hear your voices. So with that, I'll conclude my remarks and thank you very much.
Thank you, Amy and Dr. Wolf. I very much appreciate you guys coming in and helping share your stories. Amy, a great story to have, very impactful. And Dr. Wolf, the presentation that you provided, the information there was definitely valuable. So I wanted to thank you both for finishing off our panel of discussions, and I want to thank our entire panelist groups of patient ambassadors and expert faculty that have helped share their experiences, ask these common questions, and provided the answers for it as well. Before we start the Q&A portion of this evening, I want to remind everyone that there is also a post-webinar evaluation survey, a link that will be made available on the Swap Card registration page, your account page. It's available for tonight's program. We would really appreciate your feedback to help us, of course, plan future programmings, understand your needs, and make sure that we've got the topics that you're most interested in. I would like to, as you can see now, invite all of our presenters up for this evening to join us on the Q&A panel. We do ask that if due to timing, we may not be able to get to all of your questions. We appreciate your patience with us on that. But if we are unable to get to your questions, please just be sure to contact our Foundation's IBD Help Center. A lot of great workers, Jackie herself included, that are available to help support you in those questions. And then also, if some questions may be very specific to your experience, we'll try to answer them as best we can, provide you with the education and the knowledge that we have. But just as a caveat, it's always great to talk to your doctor and your healthcare team, your manufacturer team, and everyone there to help you to make sure that you are getting the best possible care ever. So with that being said, our first question comes about prices for medications. Patients, and I agree, should never have to pay such exorbitant charges for medications. And someone had asked, what can be done about this in particular? And I'd like to direct this question to maybe Dr. Wolf and Dr. Choi, since Dr. Wolf just talked about Safe Step Act, and Dr. Choi, you are in that field as well.
So I'll speak very briefly. I think I'll leave a lot of this to Dr. Choi, but I mean, there are a couple of things. Do speak with your doctor and or provider and see what options there are, what other options are. One thing that we found in our practice, we use a specialty pharmacy, and specialty pharmacies can often strike up a better price for your drugs than the standard CVS or Walgreens or something like that. So that's one option. And then another is to ask your doctor or his medical assistant or nurse, whatever, to speak with the pharmaceutical company. I think that was already mentioned, to see what arrangement, what they can do to help. Because I'd say the majority of the time, both of those options are helpful.
Yeah, I just want to echo and kind of add to Dr. Wolf's kind of statement is that a lot of times I think when the prescribers are prescribing these medications, they don't always know what the cost of the medicines will be. I think sometimes patients think that when it's prescribed, how do we not know what the cost is? And unfortunately, the insurance is a black box where things go in and then an output comes out, and we don't always know exactly what happens in the black box. So a lot of times our intent is never for you to pay these high copays. Sometimes we just may not have realized that there is a high copay. So please don't ever feel like it's something that you have to fill in that moment, pay that high cost and be like, hey, FYI, I paid $1,000 for this medicine. Is that the case? Because there are alternatives and there's alternative solutions we have. I think as previously mentioned, the copay assistant cards, patient assistance programs, as well as working on, even though this is not necessarily a preferred, but samples absolutely can help bridge us through those avenues too. So I think, especially if you run into those situations, please just work with your provider's office, because once again, there's a lot of strategies you can work on to help with the cost. And I think just kind of related to cost and copay and these kind of going high, I think there is a national discussion happening right now to kind of address this, because this is continuing to be a growing problem and is something that we definitely feel strongly about and will continue to advocate for as well.
So I'll just add one thing briefly in 10-20 seconds, and that is that I've seen multiple cases of prescription that is the patient's told it may be $1,000 or several $1,000s, and then you rework it. You submit it and say something or do it through a specialty pharmacy, and it ends up being a $5 copay. So it's outrageous. So if you hear something outrageous, just say that's outrageous, and let's see if we can find another option. And the majority of the time, one can.
Thank you both. I appreciate both of your professional knowledge and background in that situation in question. The next question, and I actually have snowballs off of that. This individual is looking, as with many of us, how to manage a large copay. The question asks, how would you encourage a patient after a grueling insurance appeal process that ends in a denial? And I would, of course, like to direct this to either Brett or Dr. Choi, since you led that talk first. And then, of course, if anyone on this panel has more information, please feel free to share.
So after the denial, well, it doesn't end after the denial. I mean, there are the processes, and having gone through a number of denials, we've eventually gotten the medications we've needed. It takes persistence. It takes organization. The more organized you are, my daughter was in the hospital, and that's when they prescribed the dual biologic, and I pulled the records for all the MRIs that she had and the emergency room visits before the hospitalization. And I said, if she's on these meds, then she won't be as sick. And it will make sense for you to be paying for the insurance company to pay for the biologics, the two of them rather than the treatments. And having the doctor's office, talking to the doctor's office, having them help with the review. One thing that both Dr. Choi and Dr. Wolf mentioned on the value of the peer-to-peer, and our doctor has been amazing on our peer-to-peers. I've had two of our doctors do peer-to-peers, but whenever you get a denial, read the letter and read the time periods. One of our denials, the peer-to-peer had to be requested and was only permitted in the first 30 days. And the doctor's office didn't realize that. They did the letter of medical necessity thinking they'd do a peer-to-peer later. And then we couldn't do the peer-to-peer later. And so I ended up having to get arrangement at a hearing where I had to submit the information. So always look at the letter and see what time periods apply and how to figure out which process makes sense. And the other thing that I had mentioned earlier, and I think Dr. Choi mentioned it as well, all of the private insurance companies I've dealt with, and I've had, at least 4 insurance companies we've dealt with over the years. I've had UC for 25 years, and my daughter was diagnosed 9 years ago with Crohn's, and my son 7 years ago with Crohn's. When you have autoimmune, when you have chronic illness, the insurance companies all have like these, either the nurse case manager or the nurse navigator, or they have different titles. But from the insurance company's perspective, they want to help you make sure you manage your disease, because you will cost the insurance company less money if you're healthy than if you're sick. But they can be your advocate, even though they work for the insurance company. They're nurses, they understand. Ours calls me every 3 weeks to ask for an update and gives me advice on how do you get the approval, and or when we were rejected, she would check the status of the appeal and gave us recommendations for how to appeal the denial. So use the resources available to you.
Absolutely. And, something I just want to reinforce again is a lot of times a prior authorization denial, sometimes it is something as simple as you just didn't hit a checkbox for something. You needed to have done this. And, all the documentation was submitted. You crafted the narrative of why this medicine is important, but to the insurance company, because this checkbox wasn't filled, it automatically gets denied. So please don't in any way feel like that's the end of everything. I think what Brett kind of mentioned, we will continue pursuing alternatives. There's many other ones. Something that Dr. Wolf kind of mentioned earlier that kind of resonated a little bit is we have been noticing more problems where people who are reviewing these and making these decisions may not be qualified gastroenterologists that should be the ones reviewing the cases. I think there was a case where we had a pediatric pulmonologist review a gastroenterologist case, which, obviously that's not necessarily their area of expertise. And that was just something that we've been kind of encountering a little bit more of. And we have been getting denied a little bit more about what peer-to-peers are able to do. So that's something that we're currently navigating in this perspective. But, kind of related to the cost and everything, there are multiple avenues. I think at each point, anytime a denial comes, as a team, because patients, you're part of the team too in the shared decision making, we just need to regroup, talk about what's our strategy of approach, make changes to the letter of medical necessity as needed, and then we resubmit. But I think what Brett mentioned, you have to read the denial letter, because there could be very specific reasons why it got denied, specific timeframes that you do have to adhere to. So those details are going to be very important.
So I'll just follow very, very briefly, because Amy asked, what can you do as a patient and everything. And I think that is help arm your doctor or provider with the right information. So help them. You might do a sample letter of what medications you've been on and what worked or what didn't work. And that's so important, because you have more information. If you provide that useful information, it'll just help us with a better letter and help us advocate for you.
And continue to, you've got to be your own best advocate. I'm always amazed that some people have to go through all this when they don't have anyone in their life and they're the person who's sick and dealing with the appeals. And at least I was fortunate that I'm the one dealing with it for my 20-year-old daughter and teaching her about the process, but helping her through it. And our doctor's office has been amazing, But at the end of the day, we're the ones that need the treatment and we're the ones that need it. So you got to kind of be in there with them.
And I just wanted to add that we do have sample appeal letters on our website. So definitely look on the website. Your doctor's office may have them. If they don't, again, just go to the Crohn's and Colitis website to download the sample letters.
Yeah, I just want to just echo off that we actually earlier had a appeal that we had to submit, and the patient actually ended up emailing us saying, "Hey, I found this through the Crohn's and Colitis Foundation. Would this be helpful?" So, I think that's great, especially, if your physician's office may not necessarily have the resources or ability to kind of generate these. I think these are really good starting points, and they can adapt it to your own situation. So I do want to echo kind of what Jackie mentioned there.
Okay, great.
And the last backup plan to remember is, if you're either in an existing treatment like we were, where we knew that the drug was working, the pharmaceutical companies can help. And our physician practice got us in touch with a pharmaceutical company, and separate from the copay assistance programs, which we participate in, and I have 2 kids and they're both in for their meds. So, it's, but the pharmaceutical companies also have support once you're on the med and you know that this is the right treatment, of helping with the continuation of coverage, even during the appeal process. So, and also, as Jackie mentioned before, on the copay assistance, the Crohn's and Colitis Foundation has great resources and the links at their website. But if you don't see it there, if you know you're going to use a particular med, ask your doc who's the manufacturer, and go to their website. Because all of these major companies, they all have areas on their website that if you look hard enough, you'll find where they have different patient programs or support programs or phone numbers. So look both ways, look through the foundation, but also look at the particular manufacturer.
Thank you all. That was such fantastic information. I love the personal experience being tied in with it as well. And kind of snowballing off of that, what Jackie had mentioned, Dr. Choi had provided an example of, there are a lot of resources available on the foundation website. And this question, may be able to be answered by you, Jackie, if you have some information on background resources, or anyone else that might have this experience as well. But this individual is on Medicare, and they're asking if, aside from that, there is any help for retired Crohn's or UC patients.
Certainly, there is. A lot of the pharma-related or manufacturers are basically for people who have commercial insurance or private insurance. But through Medicare, for example, there's a program called the Low Income Subsidy Program. And so this one is income-based. So if you have a low income, you can get up to $5,000 per year through the Low Income Subsidy Program. So you definitely want to look on that. To find that program, just look on the back of your Medicare card, call Medicare. You may also see it listed as the Extra Help Program, but there is help for that. And then there are some private or nonprofits that also have assistance programs for Medicare and Medicaid patients as well.
Perfect. Thank you, Jackie, for that summary. Anybody else have any additional feedback? They're welcome to share it as well. If not, I will go ahead and move on to this next question that we received. This individual is turning 65 in November. Happy early birthday to you. They have UC, and they are concerned that they're going to pick an insurance plan that may or may not cover the biologics that they have been using. So kind of feedback or advice to this individual, how do they make sure that they pick an insurance plan that, they don't experience that lack of coverage?
Yeah, I can take that quickly. One of the things that was mentioned earlier was to look at your insurance formulary. At the beginning of the year, when you pick your plan, look at that list of approved medication. I think Dr. Choi mentioned that as well. So again, you have to look to see if your medication is on the list. And again, just because it's on the list at the beginning of the year doesn't mean that mid-year there won't be a change. So that's the first thing you have to do, is look at that list.
Just to kind of add on to that a little bit, I think something else to consider is that list will be important with the formulary, but like Dr. Wolf and Jackie just mentioned, that totally changes. There was a time where we did a prior authorization. It said it was approved for a year, and I think 2 weeks later, they decided to reevaluate their program, and a new prior authorization was needed, and everything changed at that point. So it's hard to kind of predict over the years and how the
Right.
next year they would change too. So that kind of being said, I think that's the resources that the provider's office has and the Crohn's Colitis Foundation website has as well. You can only do the best you can to make those choices. So thinking about like the copay accumulators and asking those questions, thinking about understanding how your copays may change, donut holes, kind of things along those lines, which that should be closing. But I think those are the really important questions of kind of how the cost breakdown may change over the year as well. Ultimately, when it comes to the injection, the physician's office will help to continue that therapy. So, with continuation therapy, submitting the prior authorizations, but I think just making sure that it's networked with your physician, and then really just kind of making sure that you just understand the copay behind that and what the math will look like throughout the year.
Excellent. Thank you, Dr. Choi and Jackie, for providing that insight as well. I received a couple of questions regarding this type of scenario. So the individual is currently on Medicare and are continuing with their former employer's insurance plan. They were initially paying a very low copay for their medication. However, now their insurance company seems to be paying everything now. Both of these individuals asked, do they need to worry about this copay accumulator that was discussed earlier? So I'd love for, Jamie or Jackie to share some light on this, or if anyone else on the panel has any information.
Dr. Choi, I'm going to let you start that one.
Yeah.
So copays are definitely one of the things that are very difficult, especially when it comes to Medicare. So with injections, something that maybe I should have done a little bit more discussion is there's a difference of medical benefits versus pharmacy benefits. So medical benefits are the infusions. So that's kind of what the typical insurance company would do. The pharmacy benefit managers that you may have kind of heard throughout all the different sessions, those are the pharmacy benefits, and those are the self-injections or the oral medicines. In particular, with Medicare, with the infusions, a lot of times you will be responsible for 20% of the copay associated with that one. There are some things I can kind of help with grant assistance and things along those lines. When it comes to medicines, those ones are a little bit harder to figure out just because there are the complicated math related to the donut hole that previously existed. There was legislation talk about closing that donut hole. So a donut hole essentially means you have coverage until you hit a certain amount, and then all of a sudden the Medicare no longer would cover up until you hit another threshold. At that point, they would then resume coverage again, and that was really difficult, I think, for a lot of our Medicare patients. So that's just something that it is closing, but I would just, really important to ask those questions early on.
And the interplay between pharmacy benefits and the medical benefits is not just implicated on Medicare, and it's not. We have had infusion therapy on our biologics, and when they do bag and bill at one of the hospitals where my daughter gets infusions, I have to fill the prescription through the specialty pharmacy, but when she's at college, but when she's at home, the hospital orders everything and it gets processed as a medical. So with the same medication, separate from her injectable biologic. So it's complicated, and it just, again, it really depends on what your coverage is, what your meds are, and how like the plans work. So, and how the facility works, of whether the injection is, whether the infusion is done through the hospital or through you ordering it from the specialty pharmacy.
But a brief point that I'll make is that many of the infusion medicines are covered as a medical benefit, and so it's more affordable by and large, and there aren't the costs often that you see with the injectables. So that's a plus in many situations. But one of the huge challenges is it's not like there are 3 or 5 insurance companies and plans. Each insurance company has 100 plans. Do you know what I mean? And then companies say, well, we want this level of benefits and we can afford this cost. So it's not like one size fits all. There are so many different hybrids that it is confusing. But it makes it so important to know every detail you can. I mean, this is the most important thing to master if you have an illness like IBD where these meds are needed.
Yeah, I want to jump in with that. Certain medications are going to lose their either Part B medical coverage for buy and bill, or if they're with a corporate plan, it just won't be covered through medical benefits. So it's very important that if you have been doing the buy and bill or someone suggests it, to, as early as possible, speak to whoever is responsible for doing the prior authorization at that facility, as well as their billing people. And sometimes it's two separate departments. It's been my experience that not only was it two separate departments at one hospital, but one of those departments was completely outsourced. It was a company not even related to the hospital. They are just paying that company to do their billing. And trying to get those people on the phone, I tried for 3 weeks and I couldn't get anyone to call me back. And I'm on 6-week dosing. So at that point in time, I made the decision that it was not going to be the right fit for me. So have a plan A, a plan B, and sometimes a plan C in place. And it's always good, even if you have been on this cycle of medication, you've been doing buy and bill, check in with the billing department every so often, because you don't want to go to your infusion or injection day to find out that there's a $1,400 or $7,000 bill waiting for you to pay.
Excellent. Thank you all. I really appreciate the combination of information that you guys were able to spend towards that answer as well. We are getting close to time, so this may be the last question that we have for this evening. But again, if your question we don't get to or aren't able to answer for you, please feel free to reach out to our IBD Help Center, where we can still provide the same amount of support and resource for you. So potentially the last question for this evening, this is a step therapy question, so we'll go full circle here. Love to direct this towards Amy and Dr. Wolf first. Question asks, does step therapy include dose increases? For example, an infusion works every 4 weeks, but when I'm dosed at every 6 weeks, I'm flaring by week 5. So does it include dose increases?
So, Amy, I'm happy to leave that to you, or I think it's probably something I should perhaps take first. You know, technically, no one talks about that as being step therapy, but it is, because it's something that's not a standard covered regimen. And I see it both with intravenous biologics and the sub-Qs, where one agent that is given every 2 weeks, and I'd say 25 to 40% of patients need escalation to weekly. There are occasional plans where they say this is just not a covered benefit. But similar circumstances less often with IV, but they're happening. And so it's not what we typically talk about as far as step therapy, but it is, and it's something that we may want to consider expanding in our list of things when we go to legislators, just so that it is covered. The bottom line is, if you have, you're able to have your doctor and or their team justifying why it's necessary, and maybe how the standard dose didn't work, and insurers often ask for documentation of experience, but also articles from the literature, medical articles. And if that stuff can, and let me just add that the pharmaceutical company can often help provide some of those things, or the foundation. So if there's enough information provided, then those things can often be waived or worked out. But it is a form of step therapy. It's something that I think we need to include in our package when we advocate for everyone.
Absolutely. And just to kind of chime in here as a patient as well, I want to echo both Dr. Wolf and Dr. Choi's points earlier when talking about, yes, documenting your experience, really sharing with your provider what's going on, right? Because Dr. Wolf did share, there are plenty of literature and scientific papers, and that's what your clinical care team is there for. But you as the patient, you are the one who's an expert on your own experience and an expert on your own body. And so making sure you're really documenting that, like I have a little symptom journal that I keep even like 12 plus years after my diagnosis now, because that's really useful to look back on and really show like, hey, actually I have been increased, my symptoms haven't been great. I've missed X day number of like school or work. And I think in that way you can show a tangible effect on, hey, this medication is no longer working for me. So definitely viewing this as a partnership between your clinical care team and yourself as a patient, as well as your caregivers as well. I encourage all like pediatric patients as well. I know for myself, I was diagnosed when I was 10, and there were a lot of things that my parents and my family really helped out with as well. So really recognizing that it's a team-based approach. And I understand all of these appeals processes and the peer-to-peer can be frustrating, but recognizing we all have a small piece in the puzzle to play in order to, really accomplish our own health goals as well.
The one thing I just wanted to very quickly add is kind of the reasons why they deny those dose frequency changes. So a lot of times I think we've kind of been more familiar with the COVID vaccines going through FDA approval, of getting the FDA approval for it to be used. These medicines in their studies, they were studied at certain frequencies, like every 8 weeks, every 4, really every 8 weeks kind of being the big one. So when they submit to the FDA, that's the dosing that they submit, is saying, we would like to dose it at this. And then once it gets FDA approved, the insurance company takes that to be the only dosing that's available. So after we've experienced it for a while, and we kind of start figuring out with some people that maybe they need more frequent dosing, the drug company will not go back to re-addend that dosing frequency, because the amount of time and resource that goes into it is substantial, and it doesn't make sense for the drug company to do so, even though clinically we know that getting your infusion sooner or your injection sooner makes more sense. But the insurance companies deny it solely to saying the FDA hasn't approved it, which is totally not okay. So that's when I think Dr. Wolf mentioned we will submit literature showing, in the studies, patients have been shown to respond to it. So those are kind of the aspects. But I think, like Dr. Wolf said, being advocates for this, and maybe this is something we should be advocating for on a legislature national level, is going to be important, because really it is a burden and it is actually delaying care substantially.
Great. Thank you, Dr. Choi, Dr. Wolf, Amy, for all of that information. And I think that's a great way to wrap this up and finish our presentation for this evening. As I had mentioned, I do want to make sure that if your question we weren't able to get to due to timing, please feel free to reach out to the IBD Help Center. We have information on when it's available and how to contact it on the screen here. We'd love to hear from you, because there are a lot of good questions that unfortunately we didn't have time to meet. There is an opportunity for you to complete our learning survey through the chat box. So the survey link is in there if you're interested in providing your feedback. Again, it helps us plan for these programs, and we'll make sure that it's available to you as well elsewhere. Before we say good evening, I do want to just make sure that you have a chance to look at your chapter's local foundation webpage. It's a great opportunity to learn about upcoming events that we'll have and what's going on in the foundation and the chapter. Also, again, want to thank our sponsors, Gilead, Janssen, Takeda, and Bristol Myers Squibb, for their support. We really enjoyed putting on these presentations, and we thank everyone who has made it possible. So thank you to our patient ambassadors, our medical experts, our professional experts, and to everyone that joined us this evening. We truly hope you're all doing well and staying safe and healthy, and we hope to see you on next month's webinar, June 17th, again, third Thursday of each month, on being mindful about diet and IBD. So thank you all, and have a wonderful evening. Take care.